So, have you been there to NGH?
No.
Have you been there?
Once.
So if you haven't been there, it's really hard to kind of visualize, I think, right? I mean, you've been there. Many parts of it are very old. So the place that I gave Brent rounds was a place that was not as big as this room.
That's
and
funny.
The ceilings were much lower. I mean, the ceiling. But evidently they broadcast it to a bunch of other people. So there were, at the presentation, only maybe 70, 80 people. But they said that there were probably another 100 or so that were watching it. And when I went to dinner the night before, they had said, "Oh, some people like to ask some hard questions, so just be ready." And they're anesthesiologists, so they're kind of good natured, but there's still a couple of people that want to try to, give it to you. So I was expecting that they didn't ask me hard questions, and I felt like
or you just
I did my job, making sure that I answered things in a way that they couldn't come back with any questions. So the presentation went really well. The residents I met with over the lunch hour, and they would just kind of come in and say, "We'll give a review from the room." They didn't have anything bad to say. However, they commented on the rigor of their call schedule, and that was one of the things that was the most obvious difference.
Yeah.
So they do 24-hour shifts for almost all of their calls.
Okay.
And they actually said that they liked that, which I thought to myself, it's not that big.
Yeah.
But they, over the course of their entire time, are truly on call every further fit night. I mean, so it's like it doesn't get any better, does it? It's
Just that's how it is.
It's
All
just
year.
that's how it is. 24-hour day shift every 4 or 5 days. So I found that to be fascinating. When they do their calls, they have way more people on call than we have. They have call at a time, and that's why they have to have every 4th or 5th night.
Okay.
To be
Cover that many
called.
ORs, like
Yeah.
they have like 80 ORs. So.
Oh wow.
They have, you asked about the senior, what the senior does, and the senior resident doesn't function the way I thought that they would. They really are just running the board, and essentially.
Yeah, that's what I was wondering about. Because I remember them talking about that. So.
They're really just more of a triage person saying, okay, well, this case is going over here. They're not really doing a whole lot of supervising or managing.
Interesting. Okay.
So I talked to them about what our seniors are starting to do for their kind of nighttime week, and they thought that was really cool. And I'm like, wow, that'd be really neat to be able to be in all parts of the hospital, not just be in the charge desk. Essentially, is what they were doing. One thing that surprised me also was their scholarly activity. As a resident, you're supposed to do something scholarly over the course of your time. And, they have they're calling it an MSA, a mentored scholarly activity. So one of the residents had this MSA directly after my grand rounds, and it was essentially just like an M&M, right? So you give this background about what happened in the patient that she had on cardiac rotation, kind of root cause, like a lot of what we do for like our case conference and kind of QI stuff, but really not a profound scholarly activity in my mind, right?
And this was a senior resident?
And that was CA3, yeah. And that was what they checked off the box for their scholarly activity. And it sounds like most of the seniors do that. They do something like that. So I found that to be surprising given the resources that they have.
Yeah.
They're substantial things.
But also the culture that they breed there. I mean, it's like, I think here we're very much kind of this split thing of like you expect a decent number of residents just to go into private practice, not really care a ton about scholarly activity, which is fine, and then maybe the other half or third or something go into academics. And when you interview there, they're just like, they talk to you about like K1 grants for, and how they'll support you through that and stuff. And there's very little expectation anyone there's going into private practice.
Yeah. But it's surprising that a lot of people do.
Yeah.
a ton of people do it. So I was talking to other faculty, and they have, from year to year, approximately the same percentage of people that do fellowship versus go out and get a job.
Oh, really? Oh. That's shocking. I didn't expect that. Yeah, because definitely when you interview there, it's all about what fellowship are you going to, what grants you're going to go after, like all this, you know, how are you going to get tenure track, all that stuff, you know.
Interesting. How about if they do that to scare people?
Yeah.
We were like, we got offered one and then looked into it and we're like, oh no. No thanks.
But it's funny if they're like that way on interview day,
But that's how
then
they
that's
seemed
your
like
scholarly
based on their
activity
website.
isn't M&M.
Right.
Like that just seems, I would expect the exact opposite where it's like, you can take these months off to do, you know what I mean?
Yeah.
Like it'd be more,
Yeah.
invest in more of an academia type setting, not that. That's interesting.
Yeah, they definitely advertised to be more into.
I mean, the faculty I had dinner with the night before, they had mentioned two or three of them had said that they trained their residents, did essentially non-ACG fellowships and were on faculty, but they didn't really do, a lot outside of clinical work. And their clinical model is way different than ours. They don't have CRNAs or
Right.
AAs, and so they have a huge physician input presence. The one piece that I thought that was neat was that since the attendings are in the ORs themselves, that the residents actually get to pick which cases they want to do on the OR schedule. But they usually pick the room versus what the cases are.
Gotcha.
Which they want to work
So
with.
for here, we give the best cases to the residents.
Right.
Choose the faculty. Because there, they'll choose the faculty member over the case, which I found fascinating.
How many hospitals like do they actually cover? It's because their system is huge.
They just do one.
They just do one?
Yeah, residents.
I thought they would spread them.
Really, you don't go to like North Shore or any of the.
No, I think they said they could get maybe some cardiac somewhere else, but they're not covering those facilities for call or anything. So
Interesting.
the vast majority of their stuff is just at that one facility.
It's kind of
I guess with PDORs, it's a lot to.
Yeah, I mean they have a
That's
volume
huge.
of like.
Yeah.
Yeah, I remember when I rotated there, they have a whole floor in their that Wonder building.
Yep.
That if you're over there, they have a whole floor that's private ortho. It's
Gotcha.
a whole floor.
Yeah.
It's just private ortho, and it's like an 8-story building that 7 of the stories have ORs on them.
Jeez.
That's
And
insane.
So it's just like neuro's the top floor, and then like vascular was below that, and then like private ortho, and then general, and then academic ortho, whatever you want to call it.
Oh,
Like,
jeez.
A lot of walking up and down stairs.
Yeah.
yeah. I remember talking with Dr. European over the VA, and he was just like, when he started as an attending here, I think it was around the time you started, right? Where he was just like, he's like, yeah, when I would cover overnight, like start at 3, be like the C1. He's like, I remember running the board at MGH. When I run the board at MGH overnight, we had more ORs running than this place has running during the day. And he's like, so running the board here was like nothing, because he ran more as like a resident over there than, but he wasn't doing any management stuff. So that's interesting. I didn't expect that.
It's a good experience.
Never mind.
45 minutes to go from the airport to MGH, which is only 3.5 miles.
No.
So
Are you
that's
serious? You're like, I can
Yeah.
just walk.
I
Why am
can
I even
see
doing this?
MGH from the airport. Like I'm looking out.
There's no way, like, even if you took the T, it would still take about 45 minutes. It's amazing. It's amazing.
I'm
Yeah.
still building that like underground. It was like
No,
talking
that's-
to Logan.
It's big,
That-
big, big jump.
That's all done, yeah, like 15 years or so, but it's still a mess. Yeah, Scott, he was always so depressing. Google Maps, wherever you want to go. It's like, oh, it's 3 miles away. Oh,
1 hour.
50 minutes.
Cool, great.
So I know that the APPs, they were a little short on getting everybody out, so let me quickly see who's here.
Dr. Oliva, were you back on Monday? Oh yeah, you were, because we're at the family thing. Never mind. Yeah. I thought Dr. Hawkins' lecture was like, that was really amazing.
She's a good lecturer.
She went through so many papers in like such short time.
Yeah.
But still gave
She's
like,
given
a
that
lot of
lecture though, you have to remember, probably 100 times.
Yeah.
I kid you not. She gives that lecture at Crash. She gives that lecture.
That was almost like a board.
She does these like
She does pieces of it for the
CME conferences that you like. I went to one in Hawaii that she was lecturing at. So you see that same lecture. So she's used to it. Can anybody text Jackie and Patrick and find out where they are? I think Carly and Eric should be around here too, right?
Just the card chart.
We'll just find out where they are.
Okay.
Hey,
What's up, Eric?
you're not supposed to change before you come, buddy.
Yeah,
No?
it's a no-no.
You're
You
supposed
should
to
go
just
back.
come here.
No, just put your
You had too much time.
That's right. You've got too much time. Let's see here.
Oh, they're in the same room together.
Yeah.
Oh,
Who worked together?
Pat and
Jackie. Yeah. That's why I'm wondering if they got trapped in a room or something.
I'm close to Pat.
Did you get this first, Dr. Oliva?
You'll have that every week.
What?
Yeah.
Every week.
Cookies too. Dan Ford. Does anybody have his info?
I just texted him.
Did you?
Texted him.
Dr. Oliva.
Ooh, there's avocado on that.
Wanted me to let you know we're in 2007.
Nice touch.
Like, what are you on right now?
I'm on the rounding paint service.
How's Ian doing?
He's doing really well.
Yeah.
Yeah. He helped me out like both days, but yesterday, just getting me up to speed really quickly.
Awesome.
Yeah.
This is his second week, is that right?
Yeah.
You fell over.
No, so
He's an
intern.
Yeah.
Oh,
They have interns on them.
that's right. Okay. Nice. I think that's awesome.
I think so too. I think
Very
it's
cool.
going to make a
Feel a
huge
little more part
difference. I think it's going to make a big difference for our CA1s to 3s, but also for them down the road to be able to do other stuff over there.
Yeah.
Use a little extra meeting to intern here also. So it should be kind of nice.
Yeah, they go through Pre-Procedure Services Clinic, STICU.
Oh, bigger. Yeah, that's good.
Yeah, nice.
Mickey's good, but it's different. Yeah, it's not exactly the same stuff that you're dealing with.
Principles. How's the service doing?
Pretty good so far, man.
Yeah, that's good.
Yeah. Except for shocks. But
Some
39 cards.
Oh gosh.
Hypovolemic hemorrhage. No, listen.
Did Jackie or Patrick respond at all?
No.
Jackie just said they just left.
Oh.
Thanks, man.
orange beer. Actually, I can.
Yeah, sure thing. Toss it if you need or Steven over here. Or Strock.
Hey, how you doing?
I think it's a pretty quick transfer.
That's just in a nod.
I just like,
There's 2 chords, yeah.
There's food, Peter, if you want some. Sandwiches and stuff.
You want transplant? No, you just got that one transplant, right?
do you get food?
No, I thought it was an AO.
Yeah, Peter, I was
Ted
like,
or
seeing
Nick,
bolt
could
out of the
you
locker room. I was like,
text
where you going,
Lauren and Adrian to see whether they're able to make it.
Wait, what's Adrian?
They're in chronic pain.
Nick, are you going to be
I'll text Adrian.
mock interviewing us
Am I gonna be mocking you?
for boys?
Yeah, I pretty much have it down. So
Could somebody text Gisela and find out if she's going to make it?
You're at.
Hey, how you doing, Carter?
Hey, Carly.
Before you get comfortable, scan in
oh yeah.
and grab a drink or a cookie or a sandwich. It was nice to meet your mom.
Okay.
I hope she had a good time.
She did. She had fun.
Did you go to the thing on Sunday?
Yeah.
No, it was nice on Sundays.
Yeah, I'll decide that.
I texted her.
All of us CA1s were ready to prep for our World War.
I got this right.
Yeah.
All things to look forward to.
I was just.
You guys have any scares?
Oh, really?
The game was bleach.
Right, well, they
Good
were
version, but like
Yeah.
any like,
Okay.
attractive things that
Yeah.
oh, real bad.
What do you spend?
I think she's had some.
So I just.
When we were there for the version, they had the monitoring on. They're like, oh, you're having something to
I
track
don't
you
know,
right
my
now.
phone was ringing.
She was like,
The
What?
fellow grabbed it off me, answered, I did it. I didn't know any of it happened. And then he was like, I was
Strong.
like, you're in lots of patient. I was like,
yeah.
We get faster, dude.
so, yeah, I guess it didn't work for me.
I think one of the most helpful things people have told me.
All right, so as people trickle in, we'll just kind of get going.
They're gonna let us wait almost to 41 weeks, so we'll wait for this week, next Friday. We'll be induction day. Yeah.
All right, so for the CA1s, for oral board prep, the majority of the time we break out into small groups and we practice going over questions, going over concepts. And so today I just want to give background for you, but also to remind the people that are not CA1s kind of the way that the exam is set up, the way it's scored, what they're looking for, because I think that's a really important piece for you to know so that when you start getting these questions and answering, that you have a basis for why you're saying things and why you're doing things. So the nuts and bolts, it's a part of the applied exam. So the applied exam now encompasses oral boards as well as your OSCEs, and we'll talk about OSCEs on a different day. But this is essentially a half-day event where you're going to have oral board exam and 7 stations of OSCE. Hey, what's up, Patrick? And the oral board component really is what most people fear in this whole process of becoming board certified, because the oral exam is kind of subjective, right? I mean, you're talking to somebody, they're going to score you based on what you say and the decisions that you make. And it's a pass-fail exam. Fortunately for you, the fail rate on the oral board exam is relatively low. It's about 4 or 5% of people will get a non-passing score on their board exam the first time. In our program, almost everybody passes the first time. We have had a handful of people over the last 10 years that have had to take it a second time, but that's not common. So I think that owes to the fact that we do a good job of getting you guys prepped up before you take the exam. And quite honestly, when I was in your shoes as a resident, I really feel that if I were to start prepping for an oral exam earlier, it actually would have helped me for my decision making in the OR, because part of this process is understanding what's my differential, how do I think through this, how do I go through this, which helps you in the OR for your clinical reasoning. Then when you get to this oral board stuff, it just is already there. So it's 2 separate exams. You have a short stem. The short stem is just really going to be a small paragraph, and it's going to give you some nuts and bolts about the patient, the procedure, comorbidities, maybe some vitals. And then you're going to cover really 3 areas within that stem. You're going to cover the pre-op evaluation, intra-op management, and then you're going to have a section that is what's called the grab bag, which are these questions that you can't prepare for. They ask you on the spot, and you have to think of them as you are going along. The long stem, on the other hand, is really what it says. It's long. It's essentially a page or a half page of information, and it's supposed to give you all the information that you would need to know from a preoperative standpoint to care for your patient. So in this stem, you don't think about what additional studies would you get, what additional ways you would work things up. And so you're really taking all that information and then figuring out, okay, how's this going to impact me from an intraoperative and postoperative standpoint, because those are the questions you'll get. And then again, you also have that grab bag portion. Now the exam is 35 minutes long. Each of these sections here, so the first section is 10 minutes, 10 minutes for pre-op, 10 minutes for intra-op for the short and long stem, 15 minutes for the middle section, 15 minutes for intra-op and post-op, and then 10 minutes again for the grab bags for both. So that's how it's set up. And then the people that you're talking to, the examiners, there's going to be 2 of them. You have a junior examiner and a senior examiner. The junior examiner is almost always going to be doing the middle portion. The senior examiner is the one that starts off and finishes. So you talk to them, answer their questions the most. You may have an additional person in the room that is not an examiner, They commonly will have people in there observing. They could be people that are going to be examiners down the road. They could be people that are looking at the current examiners and critiquing them for their own internal process. But that's something that you have to be aware of, that there may be a third person in the room. All right, so what are they judging you on? First and foremost is your judgment of decisions. So you have to think of the way that they're viewing this. They're viewing you as a consultant. So you have to imagine yourself as though a surgical colleague or another anesthesia colleague is utilizing your specialty, your knowledge base for consultative purposes. So as a result, you need to have sufficient knowledge to have the right course of action. So if you're given a clinical scenario, you have to be able to know what the right diagnosis is, what the right management is, and a lot of that's just going to be based on practice, and that's really what your training is for, is to put you in all these scenarios and situations so that you can recall those important pieces as you're talking about this exam. All right. The second is adaptation, and this is something that we preach to the CA2s and 3s as we start going through examples. The adaptation piece is you don't want to have one set course of action and be stuck on it. The examiners oftentimes are going to try to get you to change your mind, rightly or wrongly, but you need to be able to understand the information they're giving you and understanding whether or not that should change your plan of action. The third thing is clarity. Clear, concise. And really what this comes down to is answering the question and providing enough rationale for it to make sense. So you can kind of think of this as your headline statement. Somebody asks you a question, you say yes or no, or whatever the case may be in terms of how you would manage the situation, and the rationale or reason why. So that's the way to make it through this exam in a nice, timely fashion. People get tripped up because they start talking about things that are really unrelated or additional information that is not important to answering the question. And next thing you know, they've talked for 5 minutes and taken up their time, so they don't get an opportunity to get to other questions. So that's a common reason why people will fail the exam, is because they're too long-winded. They're not allowing the examiners to get to the questions that they need to get to. Examiners, some of them are great at interrupting you. Part of that is because they need to get to the questions. Part of that could be because you're rambling, but it may not be. So if you answer the question and you give rationale and then they cut you off, don't interpret that as being a wrong answer that you've given, or that they're unhappy with the direction that you took this patient or this management. And the last thing is application. So again, dealing with changing situations. One of the things that can happen in a case, and we'll talk about some examples here in a little bit, is let's say that you have an airway that you're managing, and it's a difficult airway. You can't mask, you can't intubate. What are you going to do? And then they may change gears and say, okay, well, actually you can mask the patient. How are you going to proceed now? And that ability to have a different scenario, a different situation, and then make decisions based on that is an important thing, okay? By far and away, though, judgment is the most important thing. So that's just making the right decision, the right diagnosis. So what do you do to prep? In an actual exam, we don't do that a whole lot with these practice board exams in here, but you're going to take mock oral exams with folks, Chris Turillo over at Denver Health when you're over there, Dave Chatterjee over at Children's when you're over there, and then here, Rachel Kakmar, Joy Hawkins, Brenda Buckland. These are all people that are oral examiners, and so they will take you through the steps. And when you have those mock exams, the way it's going to work is you're going to get a stem, either a long stem or a short stem, and you're going to have about 5 minutes with which to read it and start to strategize. And one of the things that I want you to get in the habit of is writing stuff down onto that sheet. All too often, I will have these mock exams, and I'll be a junior examiner or sometimes a senior examiner for these mock exams, and somebody will come in with their sheet completely blank, or maybe just a couple of scribbles on it. By far and away, those people often do the worst. And so you utilize that time to get your thoughts down on paper. What kind of questions can you anticipate based on the clinical scenario? That's one of the things that you're going to try to do. And one of my goals for you as part of this whole process is being able to predict things that you could be asked. So the next thing that we're going to do, hey, we're going to do something fun. We're going to play Family Feud. So I want 3 teams. We've got 2, 4, 6, 8, 10, 12. So 6 people here, 6 people here. You're going to come up. You're going to have to move. You guys are going to be teams. And if you want to maybe do 3 and 3. So 3 people can stay back there, 3 people can stay here. So maybe you guys stay right there. That way you can turn around and consult with your teammates. So this is your team here. You guys will be a team over here.
Yeah, close enough.
Close enough.
Is that our Richard Dawson?
Doesn't have the So I do this with the AA students whenever I lecture with them. I've never done it with the residents, so this should be fun. So loud. Holy cow. So if you're not familiar with Family Feud, the way it starts out is I ask a question. This first question is going to be name something that you might be asked about in this exam format, oral exam format, if a patient has OSA. So your patient has OSA, I want you to start thinking about things that you could be asked by your examiner just based on that alone. So the way this will work is I'll call on a person. You say what your answer is. If it's up there, we flip the number. How you doing, Brooke? You could be on this team.
Which one?
This one right here.
Oh no.
If you get the wrong answer, you're going to hear a and you get 3 strikes for your team. And once your team has 3 strikes, that goes to the other team to try to steal the topic. All right, so that's how we're going to do it. So we're going to start with you guys getting this. So again, name something that you might be asked about if a patient has OSA. We'll start with you. And you can't consult your team for this part. It's only when you're trying to steal.
I see. What are the risk factors for OSA?
So that is a very good one. It is not up there. There you go. Gisela.
Does he or she wear feedback?
So that's also a good one. It's not up there. There's too many things that I could put up here. Patrick.
What difficulties intra-op might you have ventilating this patient?
So I'm going to give you this one in terms, see, because you said ventilating. So difficult mask, right? That's something that you could be asked about. Brooke.
Different severities in the apnea, hypopnea index.
Severity. Jackie.
I guess just generally like CO2 retention.
So that's also a good one. It is not up there. Now you guys can talk amongst yourselves and come up with one answer that you think it is, and then we'll.
The question is, what day would
Winter relapse discuss?
No. Only when you steal.
Well,
Oh, did we lose already?
Yeah.
Healing.
like energy?
Do you think you're new?
No,
You think you're new? Don't know.
All right. Time's up. What's your answer?
So, like, what post-operative complications and like management would you plan for?
So that is good, but it's not up there. So you guys won. So let's go through some of these. Hey, how you doing? So one of the things up here is difficult intubation. So there's this presumption that if they have OSA, they probably are, in addition to being a difficult mass, possibly a difficult intubation. They may be, they may not be, right? But that's something that you'll be asked about. More airway stuff. You'll be asked almost assuredly of opioids. Should you give opioids? Should you not give opioids? If so, how much? You're often going to be asked about extubation criteria. When is this person ready to be extubated? Sarah, you're going to be on their team.
We're hanging out with your friends.
So that's one of the things to start thinking about is what criteria do I have at baseline for extubating my patient? And then does that criteria change with comorbidities, type of surgery, those sorts of things, right? Pulmonary hypertension, this is something that people don't think about very much, right? If they have, so somebody mentioned, are they using their CPAP? That's a really good question, because if they're not and they have severe OSA, they likely have a component of pulmonary hypertension as well that then can be problematic for your anesthetic plan, right? Positioning. You often presume somebody with OSA is going to be obese. That's not always the case, but it often is. So positioning during the case, if it's a robotic case, if it's a lateral decubitus position, prone cases, if they've got a big pannus, those sorts of things, you have to think about. And so they can ask you questions about, well, what patient positioning concerns do you have? And then the last one is your analgesic plan. And I think Jack talked about that. So analgesic plan, if you're worried about opiates, what else are you going to use for pain control? Okay. So this is an example of you've got something, a comorbidity that this patient has. You read this. These are some of the things you need to start thinking about. How are they going to potentially pimp me, if you will, on this topic? As was mentioned, the severity, the apnea-hypopnea index, that's something that a lot of people will throw out there. So what constitutes mild, moderate, and severe? Knowing some of those numbers is going to be important, or at least knowing generally where they should be in terms of numbers. One of the things I want to throw out there with a lot of this stuff that is memorization is you're not expected to have all this stuff up here, but you need to be able to say, I don't know that information, but this is where I would look, right? So when a consultant knows their limits and is able to go find information that they need. All right. Any questions about that? Is that fun? We're going to do more. Okay, so other tips. This is something that by far and away is the biggest problem people have. Don't ask questions. So, Ted, you do great at this. If I tell you that the patient's hypotensive, how are you going to respond to that? With that being the only information you've been given. Your patient's now hypotensive.
I don't want to ask a question about the other vitals are. I would treat the hypotension with fluids first.
Good. What would you say?
Yeah, I think I would be like, assuming the hypotension is due to like hypovolemia, I would begin by assessing how much I've volume resuscitated and potentially give fluids.
So that's exactly right. So the first, I think, urge that people have is to say, well, I'm hypotensive, what's the heart rate, right? What are some other vital signs that could help me figure out what this is? Avoid that urge and simply provide some assumptions, or given this patient's otherwise healthy, this is what I am thinking about. That's really the mindset that you want to be going forward with. Don't overcomplicate things. This is, again, talking too much and trying to make this more complex than it needs to be. A lot of the times the questions are not complex. They're very straightforward, but we overcomplicate things. So if I were to give you an example, Brooke, let's say that you have a patient that you're caring for who had an MI a year ago, and they're going to have a hernia repair. What impact does that have on your decision for your anesthetic plan?
My answer to this, like, in the boards.
Yeah.
Assuming they had a stent, I would want to know what type and want to know if they're still on therapy.
Okay, so that's a good approach. Kaylee?
Assuming that they no longer have any cardiac symptoms, I would proceed with the surgery.
Perfect. So that's the better way to do it.
Damn it.
Keep your patient as healthy as possible unless they tell you otherwise. So they had a MI a year ago. Don't presume that they have all these other issues, that they're still having chest pain, that they have a low EF, and all these other things. So you say, assuming that they have had no issues since that time and that their cardiologist has maintained contact with them, then I would proceed with the case, or I wouldn't change my management, or what, if they're asking you about induction agents, you wouldn't change that if they're otherwise doing fine. But if they wanted to get at something else, they might say, no, I'm sorry, they're actually having chest pain that's new onset in the last week, right? That's going to change your mind in terms of your response very dramatically. So don't overcomplicate things. Keep things very straightforward and simple. Keep your patient as healthy as possible until they push you to some other direction. And sometimes they're instructed to do so. So you can't presume that just because you did that, you said something wrong. That's one of the things people start thinking about. Well, maybe I didn't say that right. That's why they took me over here. Think things about things systematically. So systematic thinking is going to be super important, whether that's within the body or outside of the body. You're going to get questions based on whether your machine is working, whether your circuit's working, whether there's a kink in the tube. You have to think things systematically from the outside and the inside. And so on the inside, whenever you have, let's say, hypotension, we're going to go over some questions here or possibilities leading to hypotension here in a little bit. But the idea is that you want to be thinking of it in a systematic approach. Don't focus in too quickly, have a broad differential that then you focus down based on what's relevant for your scenario. And the last thing is break down questions into component parts if needed. Most of the time, these examiners are not asking you these long-winded questions, but sometimes they do. And sometimes keeping track of what you were asked is difficult. So let me give you a scenario. You have a woman who's term pregnant, got into an MVC, presented to the ED with a GCS of 8, was intubated in the ED, is being transported to the OR for an emergent craniotomy, decompressive craniotomy, and in the elevator becomes extubated. All right, so Sarah, how would you approach that scenario? They're asking you, what's the next step of management for this patient?
I would prepare to re-intubate.
Your laryngoscope is, the bulb is out.
I would ask for back mask inhalation, ask for assistance to get help, and for a new laryngoscope and endotracheal tube. Yeah.
So you think back to what is, at that moment, the most crucial piece, right? She's lost her airway. That, by far and away, is the most immediate concern. So it might be getting out of that OR, masking the patient, or getting out of the elevator, going to the OR, masking that patient, and then intubating them in the OR if you're able to mask that patient. And so that could be one course of action. Oftentimes, RTs accompanying these patients so they can have some things available. Calling for help, which she mentioned, is tremendously important. If you go through this exam and you have not called for assistance in one capacity or another, you probably have done something wrong. They often will push you to the point where you have to ask for assistance. You have to ask for help. And so always be mindful of that, that if you need more hands or you need more resources, that I would call for help, right? Vital signs, the reason why I'm talking about these is because you're going to be asked about these every single question, every single STEM. And so if you get these down, that really makes a whole lot of things easier. So bradycardia, hypertension, hypotension, hypoxemia, hypercapnia, these are the most common perturbations that you're going to be seeing on the exam. So back to our... You like that, right? So we're going to start here for this one. Name something that causes tachycardia. And we'll start with you, Nick.
Hypovolemia. That is not up there.
Hypovolemia. Ted.
Pain.
Charlie. That is true. However, that's not up there. Peter. Oh. Not enough time.
That was brutal. Too slow.
Step outside of your anesthesia hat for a bit.
Exercise.
Too far.
That was good. That was good, though. Exercise is good. All right, Eric. So let's see here. I think of the ones that I have that doesn't fit in very nicely. So that would be it there. Can you steal it? Yeah. All right. We need an answer. What's the answer? Drugs. So I'm going to put that under this one here, which is iatrogenic. That's what we give, what we do, right? So that you stole the show. So you're up 2-0 now, right? You guys, that's the second one you want? So up here we have arrhythmia. I heard somebody say that. So that's going to really be, you want to think of terms of tachycardia as being a primary tachycardia, which is because of the heart, or secondary tachycardia because of something else, which is most everything that has been mentioned so far. So arrhythmia, SVT, VT, those sorts of, AFib with RVR, those sorts of things, right? Hypoxemia, hypercapnia. Those things are mediating tachycardia because of a sympathetic discharge, right? So that's how that works. The same is true for pain. Anemia, this is one that oftentimes, even if you're euvolemic but you're anemic, you will still be tachycardic, right? So there is a distinction there that you have to consider. For our purposes, we almost always tie them together. And then the last one on here is endocrine reasons, right? So thyroid issues, PHIOs, carcinoids, things like that.
So all of these, only arrhythmia is really primary?
That's correct.
Okay.
Yep. Any other questions on this one? All right. So coming back to you guys. I can't figure out how to change the, to take away the music. So it's one of the problems with my presentation is I do like it, but I can't get rid of it. So name something that causes bradycardia. And for this one, I want you to think just more globally, not specific things. Big things that encompass multiple causes. I think, Blake, you're up.
I would say insufflation.
So that does, and how does that do it? Through what system?
So baroreceptor reflux.
Through what system? I was gonna give it to you. Megan?
Medication?
So medications. Oh, they didn't change it.
No.
Hold on a second. I need to go in here real quick. Oh man, I think my slides got mixed up on that one. I apologize, but let me tell you. Hold on. This is the problem with having these things is I have to change them and then hide them, and so it gets very confusing. So meds being one of the options up there that was true. Of the meds, what things do we give commonly that are going to be leading to bradycardia? So neostigmine, phenylephrine. What's that?
Oh no, I just said phenylephrine is my favorite.
What's that?
Presidex.
Presidex, so dexmedetomidine, good. Beta blockers. So opiates, remifentanil is the one that most commonly causes it. Has anybody heard of the vagal thunderbolt, the CA1s? So the vagal thunderbolt was termed because of remifentanil. Remifentanil given in a big dose can lead to profound bradycardia, and they call it the vagal thunderbolt because it's opiate mediated and leads to heart rate that will dip down into the 30s oftentimes.
And is that dangerous?
It can be.
Is it reversible?
It can be reversible if you're anticipating it, right? But it will bounce back. But it can be pretty freaky for people that are not ready for that. So typically, IV pushes of remifentanil can lead to that. Usually, you need 2 or 3 mics per kilo to see it, but that's something that you do see. So again, knowing what kind of meds that we give that you can cause it is going to be important. Another thing up here, again, arrhythmia. So arrhythmia, again, for your bradycardia, tachycardia, so sinus syndrome, heart block, those are going to be reasons that you have a primary bradycardia. And then cardiac ischemia is going to be something that, if it's profound, we see this for patients that are coding oftentimes. They get to be tachycardic, and then all of a sudden they become bradycardic, and then they go asystolic. It's a typical pathway for people that have cardiac ischemia. And then what I was trying to get you to say is the vagal system, right? So it's a vagally mediated response when you insufflate the abdomen, when you have a distended bladder, distended viscus, those sorts of things. What are some other vagal stimulation pathways that we see? Oculocardiac reflex, right? So we see that for eye surgeries.
Cushing's.
What's that?
Cushing's.
Yes, so Cushing's reflex, good. So those are really the bulk of them. So vaguely mediated, we see it oftentimes on APS when we're doing procedures in pre-op. People will brady down, and it's a vagal response. Good. All right, so I'm sorry about that one. The next one, I hope that this is actually changed correctly. Name something that causes hypertension. So we'll start off on this side. Something that causes hypertension. We'll start off with, I think, Jack.
Hypertension, pain, or medication?
You can't give 2 responses. Sarah?
Inadequate depth of anesthesia.
Back to you, Nick.
Medication.
So I'll put that under iatrogenic.
Hypovolemia? Or that's hypertension, Jesus.
Yeah, I was going to say,
Sorry,
you sure about that?
We all passed our B's.
Yeah, Screw Iatrogenic, that's medication.
Okay, there must be a time.
Hypoxemia.
Hypoxemia? Carly?
With essential hypertension, like at baseline.
Oh, yeah. So primary hypertension. There you go. Peter.
Hypervolemia, renal failure.
So I have on here disease associated. So renal failure would count as that. What are some other, what's one other renally mediated hypertension that is important for us? So that we see sometimes, but it's, so RAS, so renal artery stenosis, right, or occlusion. So that's also a primary mediated hypertension. Another one that is similar in terms of a disease that we see, and Sarah's up on the OB right now, so she sees these patients. What OB patients are we looking at? So preeclampsia, right? So you have certain diseases that by themselves of having that process, you get hypertension. I think we're on you, Eric.
Endocrine.
Good. All right, can you clear the board? Jack?
Cardia.
Good job, guys.
That's victory music.
All right. Coming back to you guys. Again, this is broadly speaking, just like big paintbrush. Things that cause, or name something that causes hypotension. So I think we start back with Gisela.
Did we just do?
We did that.
Yeah.
No, we did hypertension.
And we did
But like,
Oh, we did.
like two first,
Oh, do they have this down twice?
We did not.
We did not?
Wait, no, we didn't do hypo.
No.
No, we did.
oh, we attacked
It was bradycardia, the one that I messed up.
tachycardia.
So tachycardia, bradycardia, hypertension, and this is hypotension.
I got a great answer for this one, guys. I'm on cardiac.
So hypovolemia goes under this one here. Again, broad strokes. So that's probably going to help you.
Infection.
And that's going to be, again, broad strokes, the afterload, right? Brooke? So something wrong with the heart. Good. There's one more. Can you clear it? Yeah. I can't get the other ones to disappear, so I wish I could just black that out. But
Oh, it's only 4.
it is not.
Oh my God.
I'm sorry.
Jackie? Blake?
Neurogenic. Oh.
Can you steal it?
That's fine. What did Brooke say?
Gas?
No,
Obstructive.
Yeah.
Yeah. That's cardiac.
It is not anything with neuro. I promise you.
And heart encompasses rhythm and stroke volume.
That is correct.
Who was it?
Heart encompasses rhythm and stroke volume. I said that is correct.
Oh, okay. Oh, we thought they got something right.
No.
No.
They were clarifying. Any response?
Like endocrine.
She said it. Right, so blood is the last component. So this gets back to the compartment of, and really just thinking about physics itself. So you could be, again, normovolemic, but if you have too low of a hematocrit, the viscosity of the blood is such that you can't generate blood pressure, right? So that's why it's a harder one to remember. Usually these three here are the ways that you think of hypotension just from a global standpoint. And then you can get down to the nitty gritty. So we're talking about preload. I heard some chatter about it. So anything that prevents blood flow from going back to the heart. So that can be from hemorrhage, hypovolemia from some other cause, dehydration or something along those lines. It can be something that we see in certain surgeries, right? We do some vascular cases. We do some transplant cases. What do they do commonly that affects our preload? They lean on the IVC, they clamp something, right? They're lifting the liver up and it cuts off flow. So lots of things that happen intraoperatively that lead to a decreased preload. And so understanding your surgical procedure is really important to know if, from a surgical standpoint, they are causing the problem versus something else that you can fix. The heart, rhythm, rate, those are things that are going to be really important for you. If it's too fast or too slow, maybe you're not able to maintain a blood pressure. If you don't have a sinus rhythm, that often can be a problem as well. And then if you have valvular issues, that's going to be playing a role as well. If you have any cardiomyopathy, if any part of the heart is not really working because of prior infarction or current ischemia. So those are the things that within the heart you want to think of. Afterload, I heard lots of comments about afterload. So anaphylaxis, sepsis, as was mentioned. Iatrogenic, we cause that, right? So we cause hypotension because of decreasing afterload with our drugs, but also because our drugs often decrease cardiac function on top of that. Spinal shock, neurogenic shock, that sort of stuff would be an afterload phenomenon. And then I talked about blood already.
blood again?
Yeah, so it gets back into physics. So when you are dealing with viscosity of fluids, that creates pressure differentials.
Okay.
So the less viscous the fluid is, the more difficult it is to create a pressure differential.
Thank you.
All right.
Bypass, you don't have blood pressure, right?
You do. So anybody want to comment on that that's had bypass?
You do have pressure. If you have an A line, it's a flat line. It's not a pulsatile pressure.
So it's just the mean pressure the entire time. And there's one instance where you have no blood pressure. So what instance is that? Circ arrest, right? Yeah. So you'll see those cases too. But with a pump machine, and goes for people that are on ECMO and also for people that are on bypass in the OR, they can control to some extent what that map is. And so that's something that we often are helping out with. Sometimes we're contributing to the problem in some cases. But yes, they have blood pressure. All right, so this is name something that causes hypoxia. Gonna come back, see what we do. Back to you guys, right?
Sorry. We tried to steal.
Okay.
Are you competing sport?
Not at all. I thought you guys were.
You know that now.
Name something that causes hypoxia. So I think Jack finished up on this last time, so I think it's Sarah, right?
Dead space. I don't know if that's.
Dead space. That itself is not up there. It could go under one, but it's not a great one. So.
Worsening VQ, or just VQ mismatch.
All right. So since that's a different way of saying what she said, I'll just go ahead and give it to you guys. So problems with the lung parenchyma, right? So VQ mismatch goes in that, right? But this also encompasses other reasons. So don't be saying atelectasis, don't be saying aspiration, don't be saying pneumonia, ARDS. Okay. Ted.
Not enough blood. Anemia, if you will.
That's a great answer, isn't that up here? Carly. Oh, Jesus, what am I doing? That was the last one.
Should have.
Say, like tube disconnect or machine.
Yeah, so no gas delivery, right? So tube disconnect is a common thing that happens. You have your ventilator turned off, right? So there's no actual flow of gas to the patient. Peter.
Tourniquets.
That's a good one. Hi, how are you doing?
Clever.
Yeah, thank you. That is not up there. Can you steal it?
Is this, first question, I have a question for this.
Yes.
Is this broad or is this OR specific?
This is more OR specific. This is less broad. Talk with your team.
We're gonna say the word heart.
This is a one-word guess.
So give me one instance of what with the heart.
If you're not perfusing your lungs to your hearts.
So heart failure? Sure, I wouldn't have given it to you if you said that. So with that said, what heart condition is going to lead to hypoxemia, presuming you don't have a heart failure, blood supply to the lungs being an issue? Shunting, right? So you have a right to left shunt. You have blood not making it to the lungs. So that's where that comes from. So some other things that people can shout out now that you stole that one.
Obstruction.
So obstruction, endotracheal tube obstruction is something that is up there. So obstruction for the endotracheal tube, what things can obstruct it? Mucus, very common. What else? Biting.
ENT.
ENT leaning on it, right? Kinking on the teeth or at the back of the throat.
Robot.
Blood potentially other foreign objects, if for some reason something were to be already in the lung space or in the bronchial tree that then comes lodged. Shout out some other ones.
PE count as lung or cardiac?
Would it be like one lung ventilation kind of thing? You say that?
So I thought that I had. I think I put that under no gas delivery for hypoventilation. What else?
Too low FiO2.
That would be with no gas.
That like increase
What do you do when you intubate a patient?
Apnea. Not no gas.
You check.
Yeah.
Why?
Because I said, that's why I said it.
She said it.
I'm sorry, I can't hear you. I have a bunch of people talking. So, the location of the endotracheal tube, right? So where can it be if you have somebody that's hypoxemic? It's in the wrong place. So main stemmed most often, right? If you're doing, and you hopefully don't get this case ever as a resident, but it could happen where you're doing a tracheostomy and they put the tracheostomy through what they think is the right opening and it goes subcutaneous. That would be a situation where you get hypoxemia because, again, it's in the wrong location. So location of the endotracheal tube, tracheostomy tube, whatever. What else?
Could pulse ox fall off?
Oh, that's a great one, but that's not up there. Monitors is always a great one to throw up there.
Broncho's bad.
That would be lung issues, yeah. Embolism, nobody said that. So,
Somebody said that. Oh, that was low.
I definitely said that.
did you? So it could be thromboembolic clot. It could be a amniotic fluid. It could be a fat embolism. It could be an air embolism. So these are different things depending on the surgery that you're doing. If it's an orthopedic surgery, you want to be thinking about fat emboli as being a possible source, in addition to thromboembolic emboli.
Pneumothorax would be one.
Good. That, I actually, let me see, where did I put that? Yes, I put that here. Under pleura, so effusions, pneumothorax, things that are within the thoracic cavity that can lead to hypoxemia. And then the last one is something that we see on the neuroservice a lot because we do a lot of spines with people that have deformities. So these are restrictive physiologies because of usually kyphotic disease or scoliosis. But it also can be from, this thing's covering my stuff real quick, hold on. Other chest deformities, the kids that have the, pectum excavatum. So those would be reasons that they could become hypoxemic is because they don't have a normal compliance of their lungs. What's up, Adrian?
Hello.
Just in time. You get the next question. I'm just kidding. I think that you actually might, though. Because did we start with you? No, you stole that one, right? So he's coming back over here. I think. Fine.
What is a score?
All right. So this one is name something that causes hypercapnia. Hypercapnia. Okay. I don't know where we left off. Patrick, we'll start with you.
I'm probably gonna get
These are more specific things that come
like
back.
OSA.
Not up there.
Hypoventilation.
Hypoventilation's up there. Brooke, we skipped you.
No, geez.
What?
You can't.
I was talking to myself.
Insufflation. And then you hypoventilate.
No, like inflation.
Insufflation, yeah. I can see it.
That's not up there. Next one, Jackie. Not up there. Can you steal? There's a lot of options up there.
Woo! It's my turn.
I love it.
MH.
Yeah.
All right, good job. So, other ones, throw out some other options. So that's what she said. That is a possibility. I don't
it's
have it
good.
up here. I don't have it up here, but that is something that could cause it for sure. So I have fever. I probably would have put that under sepsis, right? I don't have COPD up here.
Obstructive lung disease.
I don't have that up here, but those are good options. Like what
Well,
cardiac?
if you don't have good cardiac output, you can't deliver.
Shunting.
That is true. That is not up here either.
Like an increased metabolic rate.
Yeah. So what is thyroid? Yes. So thyroid storm, thyrotoxicosis, right? Those are things. Now, the next side over here are going to be things that are more machine related.
Absorbent.
Good.
Yeah, desiccated absorbent.
Your absorbent is either desiccated or it's completely saturated, right? What else?
Rebreathing.
Kicking valve.
So rebreathing, I could say yes, and I would put that under potentially a valve malfunction. Somebody else, I think, said that. How low can you go with your fresh gas flow?
You're at a 0.25.
So the reason why our machines can't go lower is because if it's too low, then you can get hypercapnia because you don't have enough fresh gas flow coming through. So we don't see that ourselves, but that's something that could be contributing to the hypercapnia. And then iatrogenic, right? We're causing it. We're giving them medications, both that are depressants for respiratory status or paralytics, and they're weak. So those would be potential causes of hypercapnia.
When you say how low, are you saying like what's physically possible for the machine, or what's like?
For what now? Say it one more time.
When you say how low can the gas flow go, are you saying like physically that's where the line can't go through?
That's correct. So on the old systems, we used to have an attending at the VA who would put a closed loop system, essentially adapt our circuit to a closed loop circuit and take the flows down so that you can see some of these changes that take place that you wouldn't see otherwise because the machines don't let you do it. Yeah. All right, so we're going to have a case scenario. That's how we're going to finish up. Any questions about any of the vital signs that we went over? So really those 6 vital signs that we looked at, tachycardia, bradycardia, hypoxemia, hypercapnia, what did it say, hypertension, right? Those 6, if you really get those down pat, you're going to be much quicker with your responses, much better with your differentials, so work on those. And I think that helps you in your own clinical reasoning in the OR now, as well as benefit down the road. All right, so this scenario, everybody's going to participate in this. So we have a 16-year-old female with morbid obesity and OSA, and she's scheduled for an elective laparoscopic gastric sleeve. So, oops, well, we don't need the other stuff. I'll start off with my CA3s. Sarah, what kind of preoperative evaluation would you like to do for this patient?
I would do a complete history physical as well as a airway exam and some to her heart and lungs.
Brooke, what would you like to do for your preoperative evaluation?
I forgot how old she was.
16.
Just in addition to what she said?
What would you say?
Oh, okay. I would get a complete history, including anesthetic, personal and family anesthetic history. I would do a physical exam, including an airway exam. I would go through her chart.
Kaylee, what would you say?
We do all of those, as well as assessing the severity of her sleep apnea, if she uses anything to help with it, CPAP, that kind of thing, what medication she's on.
Do we have any other CA3s? No. Pregnancy test, sure. So I think those are all reasonable ways to start. I think that when you take a question that's as broad as what I gave you, focus on the things that are important for that patient. So you did that the best in terms of saying, I'm going to focus on the OSA, figure out what the severity is, whether she's treated or untreated. All right, so let's focus on that for a moment. let's say that her apnea-hypopnea index is 64. What does that mean to you, Sarah?
I would have to look up the numbers exactly. Pretty severe.
What does that mean to you, Brooke?
He said she likely has severe sleep apnea, and I would be a little more concerned about her.
And Kaylee?
Very similar to Brooke.
So what's the cutoff? Anybody? Does anybody know what the cutoff is for AHI?
5.
For severe. It's something with a 5.
For severe? So essentially, depends on whether you're pediatric, which she would be considered pediatric at this age, right, versus adult. The threshold for severe is oftentimes 20. But what does that number mean? I want you guys to really understand what that number means.
Per episodes per hour.
Per hour, right? So if somebody has 64, what does that tell you?
Every minute. It's like almost constant.
It's almost constant. Are they really sleeping at all, right? So that's severe. So that's why I want you to start thinking about what the numbers mean. Less so about what the cutoffs are, what's moderate, what's severe, but more about what does that mean. So with that said, yes, she uses positive airway pressure. She actually uses BiPAP. Is BiPAP, Sarah, better or worse in terms of predicting somebody's severity of OSA than CPAP?
So the question is it better or worse at predicting?
So if somebody's on BiPAP versus CPAP, who has more severe
The
disease?
BiPAP person would have a more severe.
Why so?
Because it's this, they rely on not only the positive pressure, but also the release of that to exhale all their CO2.
Brooke, do you have any other thoughts on that?
Well, because BiPAP is helping with ventilation as well as oxygenation.
Right. So you got to think of this as two-way street, right? So CPAP oftentimes is really going to be beneficial. That positive airway pressure is just to maintain patency, is more for oxygenation, less about ventilation in many cases. BiPAP is usually for more severe cases where ventilation or CO2 accumulation is a bigger problem, right? Any other thoughts on that?
Does BiPAP have a correlation with central sleep apnea versus obstructive?
It does not, because it still has the same trigger, right? It still needs a trigger.
Is there empirical evidence for that, or is it just like, this is what?
Well, people that have central apnea typically are going to have to resort to having electrical devices placed to stimulate their respiratory status. Positive pressure, whether it's BiPAP or CPAP, does nothing for them. Yeah. What if I told you that her settings on her BiPAP are 16/10?
It's pretty severe.
So, Kaylee, what does that tell you?
That tells me it's pretty severe. I'm more concerned, especially in the post-op period for her.
Okay. So, what does that mean to those of you that don't know much about BiPAP? What does the 16/10 mean?
You have one level and then the second level to drive it.
Yeah, so you have a driving pressure and then you have an end expiratory pressure, right? So the lower number is your end expiratory pressure. That's essentially PEEP, what we're used to, right? So that tells you that to keep those lungs nice and expanded and atelectasis is not an issue, you need 10 of PEEP to sleep. Right? That's a lot. And then 16 for a driving pressure is also pretty high. What if I told you that this patient had a previous hospitalization because she went into respiratory failure because she broke her BiPAP machine and tried to sleep without it?
She's extremely dependent on it.
Yeah, right. Very fragile from a ventilatory status.
And it affects your like prognosis afterwards.
Yep.
Where you're gonna go home.
So let RT know how their pack you're ready for.
Good, so we'll get to that in just a little bit. So that's good thinking for kind of the next phases. But this is kind of where I want you to start thinking about. You have this patient who's morbidly obese and has OSA. Start thinking about, how am I going to gauge the severity of the OSA? If I presume that it's severe, what other testing do I need? So with what we know now, we know that this is severe OSA. I'm going to come to my CA2s now. Adrian, what would you order would you order anything for further studies before you do this procedure?
When's the last?
Don't ask any questions. You weren't here for that part. Don't ask questions.
Make assumptions. Make assumptions.
I assume.
Assuming that her sleep study was within the last year, she hasn't had any adjustments to her CPAP within the last probably 6 months, or BiPAP in the last 6 months.
She has had no changes in her BiPAP settings for the last 6 months. Would you order anything? Would you do anything? You ready to go to the OR?
I probably wouldn't order anything.
What about you, Nick?
I would order an echo, assuming she's not having one last year.
What would you do, Ted?
I would order an echo to validate for severe pulmonary hypertension.
Yeah, CA2s. I think that's everybody.
16-year-old.
So an echo is ordered, and as you might imagine, the views are poor. They cannot see the right ventricle.
I mean, if she's asymptomatic.
How would you call it?
Do you know that? Right? You didn't.
We already did the full history.
So you say, assuming she's asymptomatic. So this is the part, right? Where it's like, this is the skill piece of saying, assuming she's asymptomatic and that she has good exercise tolerance, I'm okay with doing no other studies. But you didn't say that, right? So poor views. You order the echo, but you need to follow that up with why are you getting the echo? So what would you be looking for?
Any signs of like right ventricle strain, dilation, suggestive of pulmonary hypertension.
Right. So when you're ordering something, say what you want to order and why you're ordering it or what you're looking for from those results. So echo is not going to be something that's helping you here. Are you going to do anything else? Adrian?
Probably not.
Nick? If you're worried about pulmonary hypertension, what do you want to know?
I mean, how well her right ventricle is functioning.
Yeah, so how are you going to assess that?
I mean, you could do a TE or you do a right heart cath, but
Okay.
assessing whether or not that
Are you going to do either of those?
warranted prior to.
You going to do either of those?
I feel like no.
Ted?
Assuming she is otherwise asymptomatic and has a good exercise tolerance, we do go for
So she does no physical activity. She really just gets up.
Yeah, she
goes
runs
to the
track,
kitchen.
Ted.
What
Just
you got?
going for the gastric sleeve at 16. So.
That sounds about right.
So her BMI, just to give you an indication of this morbid obesity, is 64. And then nothing else, assuming those things.
Assuming she's gone through CBT and corrective. To somehow lose some of this weight to avoid this.
So for my CA freeze, would either any of you do a right heart cath or any other thing? So you're saying yes? Would you?
I wouldn't.
Would
We're
you?
doing EKG. Look for artery strain
You
on
know, I
it.
had 64.
And do you think with all that subcutaneous tissue, you're going to have an accurate
But
ECG?
it would be somewhere to start.
It could be.
Start to see if I could evaluate.
What would you expect to see on your ECG given the body habitus? Low amplitude, right? So small waveforms. So you say yes to right heart cath. Why?
She's like super sick. That's why.
So how's that going to change your management?
Well, yeah, probably want to put a swan in her. I think that you would just be more vigilant, which you could just work assuming she has pulmonary hypertension anyway, and spare the 16-year-old right heart. I changed my mind.
Yeah. So good. So this is part of the process of thinking about this beforehand. What threshold do you have to do something versus to not do something? And at what point does a decision that you make impact your anesthetic plan or the way you're going to manage that patient? So as you said, if you go in saying, I presume that she has pulmonary hypertension, I'm going to presume that it's severe, and as such, I'm going to have my anesthetic plan accommodating this presumption. So let's move forward with doing what Adrian wanted to do from the get-go, which is go to the OR. We are going to go to the OR. Do you want any invasive monitoring, Adrian?
I'd likely get an arterial line so I can do blood draws.
And is that going to be pre-induction, post-induction?
For her, I think I would still do it post-induction.
How about you? Any other invasive lines? Or would you still do just an R line post-induction?
I do a pre-induction A line, and I would do a swan.
What do you do?
I would do a pre-induction A-line.
Is it?
I think that's it.
Okay. So monitors is going to be something that you want to be thinking about for this pre-operative evaluation. What is what I'm finding with my pre-op evaluation impacting my decisions for monitoring this patient? So that's one of the first things. You're going to be asked about A-lines and pulmonary artery catheters and other types of monitors, and you need to know, yes, I'm going to use it, and this is the reason why. Why not? So why would you use a PA catheter?
Because I would want to monitor like what her right side pressures were throughout the case. These, given her BMI, I think the approach to the case, the surgical approach to the case can be prolonged, complicated. They might have to convert to open. I could have a lot of fluid shifts during the case, which could impact my PA pressures, and I'd want to know what those were so I could manage them continuously.
So that's a reasonable rationale, right? So the idea is if you choose something, just know why you're choosing it and have a good basis for it. I think most people probably would put in the PA catheter, but that's something if you are saying, hey, if they've got to go to open or if we have complications we don't anticipate, that's something that I'll want to know that information because that's going to impact the way I manage this case. With respect to other preoperative issues, is there anything else anybody else would do? This is open to anybody. Besides potentially right heart cath, TEE, TTE, any other things that they would order?
Is drawing like a VBG help?
Potentially, right? You can do some blood gases and see where her CO2 is normally at baseline, sure.
You can just optimize and make sure the electrolytes look nice.
Okay, so some straight up labs. Anything else?
Airway exam.
Sure, but you're not going to order that. I'm thinking more
Or I
labs
think
or
on
other
BMP
studies.
On a BMP, you can look at her bicarb also.
Yep, bicarb will be helpful on that, right? So that potentially could be a surrogate for a blood gas, but you can always do a blood gas just to get a baseline. There are some people that would argue in a patient like this, they would do an ABG stick preoperatively. Because the VBG is not going to be entirely accurate for where their CO2 really is. Would anybody do a stress test? So you shook your head no. Why'd you say no?
I don't think it's going to show me.
Yeah, so it's difficult to know what it's going to show you. Now, what kind of stress tests do we have available to us? Heard exercise? Dobutamine, what'd you say?
Pharmacologic.
Yeah, pharmacologic, good. There's a nuclear stress test too, right? So you've got really three flavors of tests. You can use echo as well as a way to look at the heart function. But the idea is there's multiple ways you can do a stress test. In this patient, it may not be helpful for you. I probably wouldn't do one either. Any other preoperative concerns that people have?
With regards to the monitoring, I probably would do an A-line and then consent her for TEE in case instead of like a PA catheter.
Yep.
In case things go south, just for TEE program.
So that brings up a really good point that I want to talk about. Don't ever say anything that you would use for monitor or a technique you would use if you don't do it regularly, if you don't know how to use it. So you're going to be trained on TEE. A lot of other people are not, at least not on a more advanced level. So if you were to take me and my colleagues, if I throw down an echo probe, I could probably get some views, but it's not going to be very fast and I'm probably not going to be very efficient compared to somebody that does it more regularly. So you have to stick with the skill set that you have. What you can do is you can say, I would consult one of my colleagues that's a cardiac trained person to maybe come by the bedside or maybe be available for this procedure to throw down an echo probe if necessary. Right? That's something that you can say.
With all our pulmonary, excuse me, with all our pulmonary issues, like she probably has like a really high air scat. You could do like prehab. I'm trying to get her to have a little bit better ventilation beforehand.
Yep. The surgeon tried to get her to prehab and lose weight, and she didn't do that. She was supposed to be under 300 pounds by the day of surgery, and she got to 304, but that was from 310.
I think the most important thing would be having like a really good discussion with the parents and the patient about the possibility that she doesn't get extubated at the end, the possibility that she might need a central line, that she might need a TED, and so that they really appreciate like the gravity of and severity and seriousness of her surgery.
Yeah.
So, and that way you're kind of covered too.
Yeah.
So whether or not you do a central line.
So that goes back to, again, you got that question stem. You did think about all these things when you first read that, right? But that's how you want to start thinking about these things. What am I talking to the patient about? What am I talking about for consent or the plans for this situation? What can I anticipate intra-op and post-op, those sorts of questions. What about her body habitus? So you mentioned airway exam, right? Airway exam is going to be super important. What if I tell you that she's 4'11" and 304 pounds? What do you presume her airway exam is going to look like? Correct. So she was Malampati 4, maybe a 3. She had good neck mobility, but obviously a thick neck. Can't really tell a whole lot about jaw protrusion or a whole lot about environmental distance. So what's your plan? We'll go back to the CA3s. Sarah, what's your plan for managing this patient's airway given that information?
I'm concerned about the situation where I can't intubate, can't ventilate because she's so big. She has intrinsic lung disease as well as extrinsic restrictive disease. So I would actually elect to do an awake if I were opting intubation on this girl.
Okay, stop. What would you do?
No, I think I want to do that. I was going to say,
Before she started talking, what do you think you
before
would
she
have done?
started talking, I was going to say, due to her body habitus and her obesity, I would RSI her with succinylcholine so that it's quickly gone in case we can't intubate, and I would use a video scope.
I would lean more towards the wake by Roger because the biggest thing I'm worried about is hypoxia with her pulmonary condition.
Yeah. So these are the things that you're starting to weigh about, am I going to sleep? And if so, how am I proceeding with that? I think your approach of we're going to pre-oxygenate her, make sure that she's got as much of a reserve as possible. We're going to make sure she's in a proper ramped position, that she's in the ideal sniffing position for her head and neck. And then we're going to go fast. RSI, get the tube in. Don't waste time with trying to mask. And ensuring that we don't have a drop on our SATs for oxygen and making sure we don't have a great increase in CO2. So that's a reasonable way to approach it. So for those of you that choose the awake path, you need to be thinking about how would you do it, because you're almost assuredly going to be asked, how would you do your awake intubation? So Sarah, how would you do your awake intubation?
So I would topicalize and pre-treat with. I'd probably do dexmedetomidine with ketamine to give her a little bit of anxiolysis and sedation for the first procedure.
Okay, what would you do?
So preoperatively, I would have them suck on the lidocaine lollipop, give some glycopyrrolate in the up as well, and then once we got back there, I would do like CPAP spray after I have her keep going farther and farther back from the lollipop, and then do the spray, and then slowly introduce and see how we tolerate it. If I was going to do the fibrotic part 2, once we got in there, I would thread an epidural catheter through the little port. So when we get the view of the cords, I can spray the cords through the epidural catheter as well, to traumatize that part as well.
Have you done that?
No, but I've heard about it because I did a wake by Roger today. And we were going to think
Nice.
about doing that,
Who'd you do it with?
Stravoni.
Awesome.
Yes.
Yeah, he learned it from me, so
Yeah.
that's probably what he talked about. Awake intubations, if you haven't done much of them by the time you get to this exam, that's okay, but just have a process in mind for how you would do it. The premise of an awake intubation is to make sure that you topicalize. So think of various ways to topicalize. You have to topicalize in some fashion. Lollipop can work. I don't like that myself. The lidocaine works pretty well for getting kind of the posterior oropharynx nice and numbed up. I like the epidural catheter because you can hook it up to a 4% lidocaine syringe and just focally touch the cords and epiglottis and other areas, I mean, I can use 1 cc of 4% lidocaine and get everything topicalized.
Do they cough less than when you just do it down the scope?
Yep, they cough a lot less. So topicalization, first and foremost, you need to know how would you do it. The other piece, and you mentioned this, is sedation. So would you give any sedation?
So I would, as making sure I gave Lico, I would probably do some ketamine. Just to be worried about secretions, obviously with ketamine, but with Lico on board beforehand, hopefully I minimize.
Yeah, so that's one of the things I was going to come back to you when you said ketamine. If you're going to give ketamine, that's fine.
Yeah.
You have to think about how much are you giving and what it's going to cause. Secretions, it's almost always going to cause secretions, so you need to be thinking about that and anticipating that. So what dose would you have given?
I don't know, it's really tiny, probably start off with like 10.
What would you have given?
And start with 15, 20, and see how she tolerates that.
So increments of 10 is a pretty good place to start if you're going to use ketamine for sedation for awake intubations. Most people will take 10 to 20. Very few people will need more than 20. I got one case actually with Nick Schiavone at the very end of his residency where we were in the OR doing this awake intubation on somebody that had some cervical fractures, had an unstable spine. And I asked an APP to give some ketamine, and I specifically said, give her 10 or 15. He gave 30, and next thing I know, she's like glossing over. She goes apneic, and I told Nick, I was like, get the fucking tube in. So he was able to get down the tube in. You have to be very careful is the point, right? If you're doing an awake intubation, they need to be awake. That's the whole point of them for doing that procedure. Precedex, you mentioned. Would you use Precedex?
I find it takes a little bit of time to kick in.
What dose would you use? How would you do it?
I wouldn't do a bolus. I'd probably start it like out in pre-op, wheel her back on like, I don't know, 5. I can't remember the dose.
So the key is you got to think to yourself, am I bolusing this? Am I doing an infusion? You have to consider how much actually makes it to the patient. So if you're going to do an infusion, you have to think to yourself, well, how much does this patient need to get in order to have some good effect from the Precedex? So 1/2 per kilo is a minimum in most cases that the patient needs to get inside their body in order to get some appreciable effect. So if you're going to do 0.5 per kilo per hour, which is the setting that it sounds like you were leaning towards, you need to start that essentially an hour or half hour before so that it has time to get to that concentration. I actually prefer boluses myself when I use it, and I don't do boluses from the machine. I do it from a syringe. You can do it that way, but what do you have to worry about when you... So bradycardia. If you've got somebody that's hanging out in the 50s and 60s for their heart rate when you start this process, and you give them a bolus of Precedex, they're going to drop down into the 40s or maybe even the 30s. So pre-treating with glycopyrrolate to help with secretions is helpful, and if I know I'm going to use Precedex, I want to bump up my heart rate into usually the 70s or 80s, and that gives me enough buffer. Don't be misled. Precedex causes respiratory depression. A lot of the tests, a lot of the answers that you will give in oral board exam format is that it is not really a depressant, at least not to the same degree that propofol is, but it is a depressant. So you can get somebody who you're doing an awake intubation for, you give them too much Precedex, and then they won't breathe for you. So you have to be, from a clinical standpoint, thinking about that. All right, awake intubation is always good to cover. They often will push you in that direction, whether it be a brain-injured patient, somebody that's got cervical injury, somebody that's got a bad airway, those sorts of things. What about, okay, so we've got this patient now intubated. What about analgesic plan? Coming back to the CO2. So Adrian, what's your analgesic plan for this patient?
I would like to minimize my opioids if possible for this patient for post-operative reasons, post-operative respiratory depression reasons. I would augment my opioids. I'd like to use them mostly with induction. If I do need to use them towards the end, I'd like to use something short-acting, such as fentanyl. I would augment that with ketamine up front, probably like 0.3 milligrams per kilogram in a patient like this off of ideal body weight. I'd make sure that I'm dosing stuff off of ideal body weight, if appropriate, versus
So that's a good clarification.
On top of that, I think a Percidex infusion would be helpful in a patient like this. I think it would, especially if we've already done it, if we have our bolus from our potential awake fiberopathy, then we can just run a infusion afterward. We've already loaded and have good titers.
Would you do anything different, Nick?
Yeah, I think I would just try to have like a multimodal analgesic plan. So I agree with like ketamine, Presidex, lidocaine can also be another good one. And then I would use gas as my like maintenance of anesthesia.
What about you, Ted? Anything different?
I would, in addition to those agents, I would add on the discussion possible some sort of regional anesthetic plan, even possibly an epidural, just local anesthetic to minimize completely the chance of getting any opioids. And also, if you can't do that, it's too difficult, then at least consent for tap blocks or something to help with post-operative incisional pain.
But would you have given, now that we're in the OR, it's kind of a moot point, but would you have given anything preoperatively?
Yeah, I would have given something like acetaminophen and or maybe like a meloxicam instead, just to get the process started beforehand.
Anything else?
I would avoid pregabalin or gabapentin because of the potential for respiratory depression in her.
Unless they're already taking it.
Yeah, so she wasn't taking any medications. So that's, again, part of when you get that stem, you say, well, how am I managing this patient's pain? And you start thinking about these so that you then can say, well, these are the pre-op meds I would be giving for this patient in my effort to be multimodal for my pain control. Would you use Remy?
I think we run into more post-operative issues with pain control. Not
How so?
necessarily because of a rebound.
How so?
Pain. Just because she will have pain from the procedure. I think that
If you're doing a good job multimodal-wise, should it matter?
Are you saying Remy on top of?
Yeah, if you're doing multimodal, you give no fentanyl or any other opiates, and you're using Remy.
I still think I would.
Would you use Remy? No? Would you?
I would rather me administer the longer acting opioids intra-op with a plan for them post-op than pack you, have to rescue, and give too much.
Okay, so that's a reasonable rationale. Would you, Sarah, use Remy?
No.
Okay, so why wouldn't any of you do it?
It's expensive. Cost prophylaxis.
Expensive, you end up giving a ton of it.
She's gonna wake up uncomfortable.
Yeah, you're not getting your
Analgesia.
intra-op and that's it, and also you're gonna get that hyperalgesia.
Yeah.
I think I'd rather do an Esmol drip for her.
Okay, good. So we've heard some good options here. Magnesium, lidocaine, dexmedetomidine, esmolol, these are all adjuncts that you potentially could use. And so you can do these opiate-free anesthetics, and it's becoming something in, I think, your careers, you're going to see a whole lot more because the idea that opiates play a role in cell signaling, especially with certain cancers. I think that's something that you're going to have to get good at, is being able to do anesthetics with little to no opiates. So I'll finish up with this piece here. This is a patient that Jason Papazian and I took care of when he was a resident. So this patient came over from Children's. The folks that were her cardiologists had done an ultrasound of her heart, TE, poor views. They went back and forth for weeks about whether they should do a right heart cath. And they were wondering, whether or not that was, knowing the numbers was going to be important enough. And ultimately, when they contacted me to tell me I was doing this case, I said, I don't really care what the numbers are going to show me because it's not going to change my management. I'm going to presume that she is a severe pulmonary hypertensive and that it's not going to alter my management. So we did a pre-induction A-line. This is a woman, we did a sleep intubation, RSI. We did run Presidex and lidocaine during the procedure. She got Tylenol pre-op. I don't recall if she got anything else. I know we didn't do meloxicam, but I think it was just Tylenol. We did use remifentanil for that case. That's why I was asking you guys what you thought about it. And my thought was with that plan was when she wakes up, I didn't want any reason for her to be sedated. Now, if she was going to be in pain, then we could titrate things in. But I wanted her on extubation to have a spontaneous drive, to be wide awake, and to not have any reason to have respiratory depression. So we extubated her right to BiPAP. We had RT come into the OR. Everything went super smooth. She was really comfortable from what we had done during the procedure. Get to the PACU, and sure enough, the PACU nurse asks, this is after about half an hour or so, asks, hey, how are you doing? Do you have pain? Yeah, I've got pain. Gave 25 of fentanyl. What do you think happened? Went apneic. Almost called it like an anesthesia stat because the patient wasn't breathing. So it just goes to show you that these patients can be very tenuous, and even these small doses that we presume are not going to be problematic can be very problematic in certain patients. You have to be thinking about that. So I think this is a really good example of a pre-op, intra-op, and post-op thinking about various aspects of how something very basic like OSA and morbid obesity can impact your management during that procedure.
Have you done anything different in retrospect?
In retrospect, I think you'd have to ask Jason. I don't think I would. I think that I had the conversation with her and her family that I'm very concerned about going to the ICU, about having the breathing tube needing to be in place if you're not going to be breathing well at the end of the procedure, or if there's any hemodynamic changes that I don't really like, or I think your heart's not working. So I think we knew the scope of what could be the problem. Intra-op was super uneventful. And post-op, except for that one little segment of where she went apneic, was uneventful. And so I don't think I would have done anything differently from a global standpoint.
So how'd you get control that for her?
Yeah. So surprisingly, she didn't have a ton of pain, and that's why I got upset with the nurse. I was like, well, what was her pain score? Well, I didn't ask her what her pain score was. She just said she was having pain. I was like, well, she just had surgery. Like, you need to know what her pain score is. You can't just say, do you have pain? So it was a little bit of education on that part that I think if, after she kind of came back around, she was saying her pain was a 3 or 4. Is that tolerable for you? Yes, it's tolerable for you, right? So most times if you're worried about their analgesic plan post-op on the floor in the ICU, giving them some control with a PCA, probably with a fentanyl PCA would be the way to go in that situation where if they're too sedated, then they can't press the button, right? And you give them a small enough dose to where it helps with the pain, but it doesn't knock them out. Any other questions? Awesome. Have a good day.
Thank you.